Afternoon, everyone. Today we will be seeing about management of perinatal asphyxia. So let us see what is the definition for perinatal asphyxia. According to WHO, it is defined as failure to initiate and sustain breathing, which leads to impairment of gas exchange in the fetus. According to American Academy of Pediatrics and ACOG criteria, it is defined as profound metabolic or mixed acidemia with pH of less than or equal to 7 in the umbilical cord bed. It is also defined as persistently low Agar score of 3 or less for 10 or more minutes of life. And signs of neonatal neurological dysfunction as evidenced by the presence of seizure, encephalopathy, or persistent tone abnormalities in the baby. Evidence of multi-organ dysfunction by involvement of kidneys, lungs, liver, heart, and intestine. According to National Neonatal and Perinatal Database criteria, it is defined as if the baby shows slow or gasping breathing with Apgar score of -4 to 6 at 1 minute of life, it is defined as moderate asphyxia. If baby shows no signs of breathing or persistent Apgar score of 0 to 3 at 1 minute of age, it's defined as severe asphyxia. So, what is the incidence of birth asphyxia? 0.5% of live-born newborns of more than 36 weeks of gestation are prone for perinatal asphyxia, and perinatal asphyxia accounts for about 20% of total perinatal deaths, and it is also one of the most common cause of neonatal death and the commonest cause of stillbirth in term babies. And totally it accounts for 9% of under 5 mortality rate. So, what is the etiology for what happens during birth asphyxia? So, the following factors: any maternal cause which impairs maternal oxygenation leads to reduction in blood flow from mother to placenta, which in turn leads to reduced blood flow from placenta to fetus. It leads to impaired gas exchange across the placenta or at the fetal tissue level, which leads to increased fetal oxygen requirement, and in view of fetal hypoxia, metabolic acidosis occurs due to anaerobic metabolism. These are the factors which may lead to HIE or asphyxia in the newborn. Maternal causes include any cause of cardiac arrest in mother or as severe asphyxia, severe anaphylaxis, status epilepticus in mother. Any cause which leads to hypovolemic shock may impair maternal blood supply, which in turn leads to reduced blood fetoplacental circulation and leads to asphyxia. Fetal causes which may predispose to birth asphyxia are feto-maternal hemorrhage, twin-to-twin transfusion syndrome, severe isoimmune hemolytic disease, or cardiac arrhythmia in the fetus. Interplacental factors include placental abruption, cord prolapse, uterine rupture, which may compromise blood flow to the baby, and hyperstimulation of the uterus with oxytocic agents may predispose to perinatal asphyxia. Baby in the immediate newborn neonatal period also, certain conditions may lead to asphyxia like cyanotic congenital heart disease, persistent pulmonary hypertension of the newborn, cardiomyopathy, other forms of neonatal cardiogenic and or septic shock, respiratory failure due to meconium aspiration syndrome, neonatal pneumonia, and pneumothorax. So what happens during birth asphyxia? Following an acute insult, it leads to ischemia and hypoxia in the newborn or fetal brain, which leads to primary energy failure. So this phase is characterized by reduced oxygen supply to the fetal or newborn brain which leads to reduced synthesis of ATP, which in turn affects the functioning of ATP-dependent sodium-potassium pump in the brain cells, which leads to rapid influx of sodium along with water into the cell, which leads to cell edema. Eventually, the cell death occurs following cell rupture, which in turn leads to release of excitotoxic neurotransmitters like glutamate into the surrounding cells, and also increases calcium entry into the cell, which further aggravates this process, eventually leading to cell death. And also there is hypoxic depolarization, which leads to abnormal depolarization and signals within the brain cells. So this phase lasts for about minutes. And after this acute insult, vigorous resuscitation leads to reperfusion injury, and which may lead to secondary energy failure. In between the primary energy failure and secondary energy failure, there is a latent period which lasts for from 6 hours to 15 hours, during which we can start appropriate management, and so that the brain cells will recover completely, leading to complete resolution. Or if no appropriate management is happening, it may lead to secondary inflammation and the activation of the apoptotic cascade and progression to secondary energy failure phase. So, any neuroprotective therapy or management in perinatal asphyxia should be done during this latent period, so that complete recovery is possible. So, if no appropriate management is given, the primary phase, energy failure, progresses to secondary phase. This lasts for from hours to days. So, secondary energy failure is characterized by, because of resuscitation and reperfusion, there is increased cerebral blood flow, which leads to spreading of excitotoxic neurotransmitters to the non-affected areas of the brain, and associated cytotoxic edema, microglial activation, increased inflammation, failing cell metabolism, eventually leading to cell death. So, this phase lasts from hours to days. After this phase, there occurs a tertiary phase which lasts from months to years. This is this phase causes tertiary brain damage as evidenced by decreased myelination, decreased plasticity, reduced number of neurons in the newborn brain, which leads to permanent sequelae like HIE, hypoxic ischemic encephalopathy, and relative developmental delay and developmental arrest. So, in this tertiary phase, because of this oligodendrocyte maturation arrest, impaired neurogenesis, axonal growth, and altered synaptogenesis all leads to these myelin deficits and the decreased plasticity of the brain. So, our aim of therapy should be to prevent the progression from primary energy failure into the secondary phase of injury. So, what are the clinical features of encephalopathy? We are grading the stage of encephalopathy based on Sarnet and Sarnet staging. There are three stages: stage 1, stage 2, and stage 3. The main the parameters which are considered are autonomic parameters, pupils, and reflexes, deep tendon reflexes. Autonomic parameters in stage 1 is the baby has a generalized sympathetic tone, and the baby is hyper alert and shows full wakefulness. Whereas in stage 2, there is generalized parasympathetic tone. Baby can be lethargic, uptended, reduced tone with strong distal flexion. Seizures is the hallmark of this stage 2. And stage 3 is characterized by profound decreased level of consciousness, flaccid tone. Seizures are less common in this stage, as depression, perinatal depression or depressed brain function prevents the further progression of seizures. So there is no clinical evidence of seizures in this stage 3. On pupillary examination, stage 1 is characterized by mydriasis, stage 2 is characterized by meiosis. Deep tendon reflexes are increased or brisk in stage 1, whereas they can be normal or increased in stage 2. In stage 3, the DTRs are depressed or decreased. And also, stage 2, because of parasympathetic tone, is characterized by bradycardia and increased secretions. Stage 3 is characterized by abnormal EEG findings. but no clinical evidence of seizures. What is the management of perinatal asphyxia? So, the perinatal management is we have to categorize or group high risk pregnancies and ensure delivery in a tertiary care center. Anticipation is the main thing of prevention of perinatal asphyxia. And in case of high risk deliveries, continuous cardiotocography should be done to monitor for fetal heart rate and fetal well being. And fetal scalp monitoring should be done in case of pH monitoring should be done in case of suspected perinatal asphyxia. Delivery room management consists of supportive care and further definitive care is done in NICU. So supportive care includes the care which is started before definitive management like therapeutic hypothermia. In some resource limited settings, the supportive care may be the only mode of treatment, whereas definitive care is initiation of neuroprotective strategies like therapeutic hypothermia and other newer treatments. So, in supportive care, the following parameters should be monitored, like temperature, passive cooling should be started under strict temperature monitoring of the fetus. Passive cooling includes switching off the warmer with strict monitoring of newborn's temperature, and the newborn temperature should be maintained above 33.5 degrees Celsius, and the airway should be cleared of any secretions. Assisted or invasive ventilation can be provided if needed, and normal normocarbia should be maintained, and normal oxygen level should be maintained. Circulation includes management of shock with fluids and inotropes if needed. Fluid and feeds should be IV fluid should be started immediately so that normoglycemia is maintained and fluid overload should be avoided. Enteral feeds can be started if baby is stable. Following medications are used in case of asphyxia. Calcium, as there is a risk of development of hypocalcemia, and anti-epileptic drugs for the management of seizures. The drugs which are the choice, anti-epileptic drugs of choice are phenobarbital, followed by phenytoin or fosphenytoin, followed by benzodiazepines, and followed by levetiracetam. During treatment, the following things should be monitored. Temperature and the CNS examination should be done like 8 hourly. The following things should be noted, like watch for any occurrence of seizures, and sensorium should be checked to see if there is any encephalopathy. And the tone abnormalities also should be assessed. Respiratory wise, airways and breathing should be checked every third hourly. Cardiovascular monitoring includes checking for heart rate, BP, central venous pulse, peripheral pulses every third hourly. Renal monitoring includes looking for urine output to see if there are any fluid overload features. Metabolically, blood sugar should be checked 6th hourly or as indicated, and blood gas analysis should be done if there is any deterioration in the status of the baby. Fluids and feed, fluid restriction should be given, and vomiting, abdominal distension should be looked for, or if there is any feed intolerance as indicated with pre-feed aspirates. So the definitive therapy for birth asphyxia includes therapeutic hypothermia, other newer neuroprotective strategies. Therapeutic hypothermia. So it is the only definitive or standard treatment for management of birth asphyxia. However, it is used only in selected units in India. It reduces mortality and neurodevelopmental disability which is associated with hypoxic ischemic encephalopathy. So what is the aim of treatment by doing therapeutic hypothermia? It prevents the progression from primary to secondary pump failure, and it also contains and reverses the damage due to hypoxia. How does this therapeutic hypothermia work? It reduces energy use in the baby and also reduces free radical induced injury to the brain, reduces the severity of secondary pump failure so that the extent of brain injury is reduced, and also inhibits inflammation, and also reduces the production of pro-inflammatory cytokines. So before starting therapeutic hypothermia, there is an inclusion criteria. babies which can be included in this criteria only are taken up for therapeutic hypothermia. So the baby's gestation age at birth should be 36 weeks or above and birth weight of 2 or more kg. There should be no external congenital anomaly. And along with this, there should be an evidence of asphyxia, which is indicated by a history of acute perinatal event or cord blood or blood gas analysis of less than at cord blood or blood gas, which is done less than 1 hour of life, showing a pH of 7 or less than or 7 or a base deficit of 60 or more millimole per liter, or if there is ABGA score of less 5 or less at 10 minutes of life, or need for assisted ventilation at birth and which is continued for more than 10 minutes of life. This is the evidence of asphyxia. Presence of any of these is an inclusion criteria for that therapeutic cooling. And there should be evidence of moderate to severe encephalopathy by clinical examination, that is by Sarnet and Sarnet staging, or as indicated by an amplitude integrated EEG finding. Exclusion criteria for therapeutic hypothermia: any baby with a chromosomal abnormality or presence of external severe congenital anomaly, bleeding diathesis as evidenced by obvious bleeding, or any major intracerebral hemorrhage is suspected. These babies cannot be taken up for therapeutic hypothermia. So, what are the devices by which cooling is done? Selective head cooling can be done by using a cool cap and the temperature is maintained around 34.5 degrees Celsius. Whole body cooling can be done by whole body mattress. It is a servo control cooling technique. Here, the temperature is maintained at around 33.5 degrees Celsius. So, this is a cooling cap. Here, this cap is placed over the baby's head. This is a flexible cap. It runs cold water or another coolant material through this cap, through the channels present in the cap. This cold liquid, which is passed through the cap, draws heat from the infant's body and reduces the temperature of the brain. So, this is selective head cooling. And whole body cooling is done by using whole body cooling blanket or mattress. The infant is placed on the cooling blanket. It is the infant should be naked except for a diaper. This cooling blanket, this is connected to a coolant device, that is servo control coolant device. So the set temperature of 33.5 degrees Celsius in the servo control cooler will adjust the temperature of the water which flows around this mattress, so that the baby's temperature is reached to the set temperature of 33.5 degrees Celsius. Whole body will be cooled in this process, and the baby's temperature is continually monitored by placing a rectal probe. So other devices, which are low cost devices, which can be used in less economic or resource limited settings, are frozen gel packs and face changing materials like Miracradle. So this is Miracradle. This consists of 4 parts. The cradle is this is a cradle which is a plastic structure which serves as a framework for placing all the other components of the coolant system. And this third layer, this is a bottom layer. This consists of 3 phase changing materials. They are placed at the bottom. They passively extract heat from the newborn's body. And this is a middle layer, and it is used to quickly bring the temperature of the neonate down to 33 degrees Celsius. This is the mattress or a gel-like board on which the baby is placed to and provides a smooth surface for the baby to lie comfortably. Okay. During therapeutic hypothermia, these parameters should be checked in a regular interval. Temperature should be checked once in every 15 minutes until 33.5 degrees Celsius is reached, and then hourly should be checked. For respiratory wise, a baseline blood gas should be done, and it should be repeated at 4, 12, 24, 48 and 72 hours, or as indicated clinically. Cardiovascular system monitoring includes to look for any bradycardia and reduced cardiac output, and echo can be done if indicated clinically. And fluids, electrolytes and renal parameters should be monitored, and according to urine, fluid should be titrated according to urine output and weight of the baby. Blood sugar should be monitored every 6 hourly. Renal function test, liver function test, and electrolyte should be assessed as a baseline and then once in every 24 hours. Nutrition, no enteral fish should be given till rewarming is completed. Hematological parameters are babies are more prone for abnormal coagulation during hypothermia. So, thrombocytopenia and a baseline coagulation profile including PT, APTT, INR should be done, and thrombocytopenia CBC should be done to rule out thrombocytopenia before starting cooling, and also should be CBC should be monitored once in every 24 hours. Adequate pain management and sedation and sepsis prevention can be done by using morphine, fentanyl, and required appropriate antibiotics. CNS examination should include a neurological examination, amplitude integrated EEG to monitor or video EEG to look for any subclinical seizures, neurosonogram to rule out intracranial hemorrhage, and MRI should be done within 1 to 7 days after of birth. So therapeutic cooling is done for a total period of 72 hours. At the end of 72 hours, slow rewarming should be started at the rate of 0.2 to 0.5 degrees Celsius per hour, slowly over 6 to 12 hours, until a temperature of 36.5 degrees Celsius is reached. Once rewarming is started, the baby can be gradually started on oral feeds, and continuous monitoring should be done on the next subsequent days. There are certain newer therapies which are emerging for the management of asphyxia. It includes use of endogenous substances and exogenous substances. In the endogenous substances, certain therapeutic interventions are under clinical trials. Those are use of erythropoietin, darbepoetin, use of stem cells, and melatonin. Those are in the preclinical studies include remote ischemic post-conditioning and endocannabinoids. Exogenous substances which are under clinical trials include monocyanogangliosides, xenon, allopurinol, topiramate, and magnesium sulfate. Those under preclinical trials are argon and azithromycin. So these newer strategies work by reducing the processes which causes progression from primary to secondary pump failure. Like melatonin reduces apoptosis and reduces inflammation. Cannabinoids increases repair of the damaged cells, decreases apoptosis, decreases excitotoxic neurotransmitters. And erythropoietin increases neurogenesis, reduces apoptosis, reduces excitotoxic neurotransmitter release, and allopurinol by inhibiting xanthine oxidase reduces cell death and has a neuroprotective effect. Stem cells by mechanism of immunomodulation also have a role in neuroprotection. So these are the new strategies of treatment that are emerging for the treatment of birth asphyxia. So, supportive care and early institution of therapeutic hypothermia in babies with moderate to severe birth asphyxia reduces mortality and also have a better neurodevelopmental outcome in these babies. Properly equipped NICU and a trained personnel along with careful monitoring of the parameters are required during cooling and rewarming. After acute management of perinatal asphyxia with cooling or supportive care, a long-term follow-up with multidisciplinary team is essential for continuous developmental assessment to identify early developmental delay or any abnormalities, and appropriate management should be instituted so that a better neurodevelopmental outcome can be assured. Thank you.